Okay, so this is how the images are produced, and this is an actual picture of an actual thermogram being performed, and that's the camera there. There's a computer image of what a thermogram looks like, and then there's a little camera just to the right of that. It's kind of like a big bread box, basically. And the point is that there's no compression, nothing touches the patient, and all these things are very popular. And because there's nothing that comes out of the camera, unlike a mammogram, we put the energy through the breast. In the ionizing radiation, the energy comes from the outside, goes through the breast, and that's how the image is produced. The thermogram image is produced by a person's own energy. Won't go into it much tonight, but it always fascinates me. It's called digital infrared thermal imaging. The image is actually produced by the infrared light that all living things emit, which happens to be virtually 100% the same as the temperature. So yes, we're really imaging the light, but we can really, it's kind of a one-to-one thing with the correlation with the surface temperature. So that's really what we're evaluating. So this is basically a normal thermogram, a typical what a thermogram looks like. There's an anterior view, there's 2 oblique views and 2 lateral views. And we could assign any color we want, but the white is considered as the hottest, the red is the next hottest, then the yellows, the coolest are the greens and blues. Blue is the coolest. The computer could assign any color, but that's the accepted protocol. And it's important to remember that thermography records skin surface temperature only. That's all it records. It's easy to look at a thermogram and kind of mentally try to make it into a mammogram, because all of us, whether a physician or not, are used to seeing structural tests. All of the virtually all of the radiologic tests are of anatomy. And it's easy to look at a thermogram and see a little red spot and say, oh, is that a tumor? We don't see tumors, we don't see cysts. We see thermal changes on the skin that are associated with those things. So again, we don't.
Can I just interject?
Yes, please.
That actually, the corollary to that is that thermographic results are independent of breast density, which I think is an important point.
Yes, it does. It doesn't matter how large the breasts are. It doesn't matter how small the breasts are. I mean, how dense they are. The temperature is completely independent of that. So that's one thing that doesn't matter, as opposed to the mammogram, where breasts that are not dense, we can see much better. Breasts that are dense are a little harder to see. And the key thing to remember is because thermal regulation of the skin is all done through the sympathetic nervous system. It's part of our automatic nervous system, and it regulates the thermal temperature of the skin. So actually, what we're seeing in thermography is really a test of the sympathetic system. And as it turns out, pathology, no matter what it is in the breast or any part of the body really, will affect the sympathetic system, and that's what gives thermal changes on the skin. So the important part is, I would say virtually everybody that I talk to, and this is what I believed in the beginning too, before I was trained to read thermograms, is we think in terms of breast cancer, oh, okay, we see the cancer, there's what so-called neovascularity or new vessels, or creates warmth around the tumor, and that's what the thermogram sees. And in reality, that's not the case. If the tumor gets big enough, then yes, you can see heat from the vascularity around the tumor. But in reality, we're really testing the sympathetic nervous system, and we're seeing the results of a disturbance in that, which happens to correlate with pathology at different places in the body. Right now, we're talking about breast. And again, the thermography is basically, we're evaluating temperature regulation. and again, I do want to emphasize, we only see the skin surface, the top 5 millimeters of the skin. We don't see deeper than that. Okay. The other piece, the other part is, now these are 2 thermograms. So the question is, are these normal or not? And it's kind of a trick answer because you don't really know without a baseline and then a follow-up 3 months later to make sure that the patterns are stable, because everybody's thermal patterns are different. Both of these people are normal, but I only know that because I've seen follow-up images. So the key thing is, rarely can you look at just one image on any given day and totally say that that person is fine, because the patterns vary with everyone. So we really, the standard breast protocol is you do one today, you do a follow-up in 3 months to quote unquote establish a stable baseline, and then go annual if people desire. And it's called a thermal fingerprint because, again, it's very unique and it's different in anybody, just like your DNA, just like fingerprints, just like snowflakes. And this is an example of someone year 1 through year 15. Actually, there were more than this. I just sort of coned it down to this. And you can see from year to year, there may be some slight changes, but the patterns are the same. It may be slightly warmer, slightly cooler from one year to the next, but the thermal patterns are virtually the same from year to year. And obviously what we would be looking for is a difference. This is a case where this was a baseline on the top, and then across the bottom there were follow-up thermograms at 3 months, 6 months, 9 months, 12 months. At the 3 month, the thermologist thought there might be some changes. It looked like maybe some subtle changes. So rather than going to a year, they went to 6 months where there definitely were some changes. A mammogram somewhere along the road at 3 months or 6 months, I believe, was normal. I think there was a mammogram like at 9 months or 12 months, and they found a small DCIS. And this is, which is duct carcinoma in situ. It's the earliest type of cancer that we find. And this is a key slide because really this is one of the huge things of thermography, that it can potentially see thermal change. Again, this isn't a cancer that we're seeing. We're seeing skin changes based on a cancer that's deeper in the breast. And a thermogram, it's possible to see a breast cancer, the findings associated with the breast cancer, earlier than a mammogram does. But I have to say this, the key point to this is it doesn't always do that. It's not 100%. The one study that I read talked about 70% of DCIS was seen on the thermogram prior to the mammogram. So it's something that it can do. It doesn't always do it. Like every imaging test, nothing's 100%. But when you talk about early detection, this is actually earlier detection, when it does show it earlier. It's earlier detection than a mammogram can do in these cases. Okay, so again, sort of an overview of thermography is there's no radiation, no compression. That's the huge benefit. Potentially, it's the earliest detection that we can do, sometimes up to 10 years earlier, which creates sort of a problem in the traditional medical world, the conventional medical world, because if there's a cancer developing and we can't see it on our traditional tests, there isn't anything the medical field can really do about it. So we'll talk about that as we go a little farther, but it's a very important risk marker. And this is where John can kind of take over.
All right. Yes, I'm going to use this slide and the next slide as a springboard to just discuss a little bit of the literature, in particular 3 studies that I think are particularly compelling in making the argument in favor of thermography. We're talking about thermography as an important risk marker, and this is where I think that thermography excels. this is what thermography can offer that no other breast imaging modality can. There was a study that was published in Cancer in 1980, in which they followed over 1,200 asymptomatic women for 12 years who had normal mammograms, normal breast ultrasounds, but abnormal thermograms. And this is precisely the scenario that in part caused thermography to fall out of favor, because it was thought originally that there were just way too many false positives and that this was not a reliable exam. However, in this particular study, which, as I said, went on for 12 years, within 5 years, more than 30%, more than a third, almost 40% of patients developed breast cancer within 5 years. So the thermograms weren't falsely positive. They were abnormal earlier than everything else. There's another study which was published in 1985, which looks at individual risk factors and how significant each was as a predictor of future development of breast cancer. They looked at family history, they looked at parity, how many children a woman had, previous pathology, and also abnormal thermograms as risk factors. And of these, abnormal thermograms were associated with a 23% incidence of breast cancer within 10 years. This was 3 times higher than a first-order family history. And I've seen other studies that say that that claim that an persistently abnormal thermogram can be up to 10 times more significant as a risk factor than a first-order family history. And that's usually what we emphasize when we speak to women. We ask them, did your mother, your daughter, your sister ever have breast cancer? So this is 3 to 10 times, an abnormal thermogram is 3 to 10 times more significant as a risk factor. In this study, the only risk factors that were more significant were a previously abnormal breast biopsy. The other thing of note in this study is that as far as false positive thermograms go, over a period of 10 years, the number of false positive thermograms, in other words, thermograms where no cause was found for the abnormal thermal pattern, was less than 2%. And finally, these authors concluded that thermography was I'm sorry, I misspoke. The authors concluded, and the study included over 11,000 women, that it was highly desirable to use, and I'm reading here, highly desirable to use screening resources such as mammography and ultrasound for women at high risk rather than for the population at large. And thermography as a risk factor and early warning signal can play a major part in identifying a high-risk population. Could you go, Tom, to the next
slide?
Yeah. So here, the reported sensitivities vary. You see figures as low as 39% and as high as 98%. Tom and I are in agreement that the reality is somewhere in between. I think it's probably in the range of 80%. Early detection not consistent. That's interesting in that from what I've been reading, there are spikes in the sensitivity of thermography. At thermography, the sensitivity spikes for tumors 5 millimeters and less in size. Then the sensitivity decreases and increases again for tumors over 2 centimeters in size. So that truly its best use is as an early detection tool. I wanted to go back and talk about that 39% sensitivity. This happens to be my favorite study to talk about. It comes from radiology, and it was published in the journal Radiology, and it was published in 1977. And one of the things I like about this study is it's very often cited as the benchmark study that definitively debunked thermography as a viable breast imaging tool. As recently as a year ago, I saw this article referenced, and again I'm going to read in the following way. In 1977, Feig and his colleagues reported results of a very large study comparing mammographic and thermography breast cancer screening in 16,000 women. Sensitivity of thermography was 39%, specificity 89%. Authors concluded that thermography was not a viable screening tool. Now, if all you read is the abstract, 39% sensitivity is definitely the takeaway. However, if you go and explore the full text of the article, what you find is that objective criteria for thermographic interpretation were adopted late in the study. If you only look at the last 5,300 patients screened, the sensitivity of thermography increases to 75%. And this is using 1977 technology. The other interesting point was that far from concluding that thermography was not a viable screening tool, the author's published conclusion was that the use of thermography in selecting high-risk groups for follow-up screenings shows theoretical promise and should be further investigated. So this article that's so often used to discredit thermography actually shines a very favorable light on the technology. And that's one of the reasons that I love talking about that. And I'm going to hand it back to Tom at this point.
Okay, what do we have? Okay. Remember I talked about establishing a stable baseline, and it's important to have two studies at least 3 months apart to find out what the thermal patterns are, what they normally are, what that person's normal is. And obviously in terms of breast cancer, we're looking for something developing. We're looking for no heat to an area of heat, like the other slide I showed, the original one of the DCIS. We're looking for so-called hot areas or warm spots that are continuing to change. That's what we see with breast cancer. This is a case, I think maybe from 2 years ago, this was a case that I read actually, and you see on the left side of the screen of April 20, this just sort of kind of diffuse warm areas, pretty symmetric, a little more on the right than the left. It's not unusual for us to see that at all. And then this was the follow-up 3 months later, and there's significantly less warmth there. That the thermal patterns have, the overall pattern is the same, but everything is much cooler than it was. And this patient, or this person, had undergone some herbal therapy and also had a significant diet change. They were under the care of a holistic practitioner. And to me, this is one of the really big things, another big thing that thermography can do that mammography cannot. And that is that thermography can actually monitor a woman's breast health. A mammogram, they can find cancers, they can find them small, they do generally a good job, but all they're doing is looking for cancer. Otherwise, they don't really have a reason to exist. That's all they're showing. And this actually can show differences in different treatments and different diets. The thermal patterns can change. And that's the whole point of finding a cancer earlier, before it's actually a tumor, when it's only cancer cells. That's the time that a holistic practitioner can actually work on the diet, can do different kinds of alternative quote-unquote treatments to potentially reverse a cancer that's maybe developing, but not big enough to coalesce into a tumor. A cancer isn't a cancer from the conventional medical point of view until it's big enough for us to see. And in reality, it takes like 8 years or so. Every cancer is different, but some studies show an average of 8 years from the time the first cancer cell to the time it's big enough to actually see a tumor. And thermography really can potentially pick it up in that 8-year period when it's early enough to potentially do something about it other than surgery, chemotherapy, and so on. So I really like this slide because it shows that the thermal changes go both ways. Sometimes with treatments, we can watch things improve. And what I've seen also is that in that way, thermography is kind of like biofeedback. When a person sees this and says, wow, you know, a dietary change made that much difference, they get very motivated. And again, that's something the mammogram doesn't address, doesn't do. I made this slide just to kind of show that really a thermogram is much better understood by the quote-unquote alternative medicine, which is a term I don't like. I just use it because it's pretty well grounded in the culture. But chiropractors, acupuncturists, doctors of Eastern medicine generally understand thermography a lot more. When you think about it, it's really evaluating our energy field, right? It senses the light that we emit. So it really is a whole different way of looking at things. So it's more understood in the alternative world. It's less well understood in the conventional medical world, where the structural tests like mammograms really predominate. So I think I like this slide. I made the slide, so I guess I like it. To really, it really explains why you could have a questionable thermogram or an abnormal thermogram, take it to your regular doctor and have them go, this doesn't help me at all, because it's a very different paradigm. The information is incredibly useful, but it's not useful to a breast surgeon unless you have a breast cancer. And ideally, we all hope to intervene in the disease process before the disease actually manifests, which is where thermography shines. Basically, inflammation is a precursor to disease, and thermography is super good at finding inflammation. So we're just kind of go through some other things that are non-breast. What are the other some of the other applications of thermography? Here's a 41-year-old with carotid artery inflammation. And this is a lot. This is kind of one of my favorite topics, actually. It's a lot like breast thermography in a sense, because this person has obviously inflammation in both carotid arteries. Now, this person could go to have an ultrasound, a Doppler ultrasound. You can have them, you know, you can go to your doctor and have it, or they have screening things that you can just go to yourself, which may be normal, quote unquote normal. And again, the conventional medical view would be, well, see, I told you the thermogram wasn't worth anything. But in reality, what this shows is inflammation. It's excellent showing inflammation, which is a precursor. The endothelial inflammation is a precursor to stroke, to actual cardiovascular disease. So this, again, is where a holistic practitioner can say, look at that and say, wow, there's inflammation there. It's probably worth doing a carotid ultrasound to make sure there's not a big plaque. But just because there's not doesn't mean that there isn't something going on. And again, this can find disease as it's developing before it's actually manifested. If this person might be at risk for having a stroke when they're 75, right? As this inflammation goes over a lifetime, over decades, that's what causes it. But if you become aware early, then you can change your diet. There's plenty of ways to decrease systemic inflammation. So carotid artery inflammation is something that we see a lot. These are two separate patients. The hands are the extremities are normally warmer from the top, and they get cooler as they go more peripherally. That's the normal sort of range gradients as on the bottom. On the top, you can see it's the reverse. The hands are very, very red, very hot. And this is very typical for diabetic changes. Sometimes We can see this even earlier than the blood sugar rises. But a lot of times we see this is very sensitive. A lot of times we see this in somebody that doesn't really know that they have diabetes yet, and maybe pre-diabetic. And again, it's due to the sympathetic changes, because diabetes is known to cause in the periphery in the hands and feet. You want to do this one, John? This was yours.
Sure. Yes. This was interesting. This was a 63-year-old who actually came to us with a recent diagnosis of ulcerative colitis. And aside from the, pardon me for looking off to the side, but the images are on my second screen here. Aside from this clear vertical pattern of hyperthermia at the left lateral aspect of the abdomen, which is consistent with the colonic dysfunction, which we know this patient has, when we looked at her back, she's got a significant amount of hyperthermia over the sacrum, and that's interesting because there is a known association between ulcerative colitis and sacroiliitis, which is what I think we're seeing here. And then the next slide. So this was a 55-year-old with a peptic ulcer, and this was confirmed with, we know this through endoscopy. You could never make that diagnosis on the basis of a thermogram alone. You can see a lot of asymmetric hyperthermia in the left upper quadrant of the abdomen. There's also hyperthermia extending superiorly into the chest in the midline over the sternum. That's something that we can see with gastroesophageal reflux. I don't know that that's the case in this patient. I do find that finding is more useful in male patients than female patients, because in females you often have hyperthermia in the cleavage between the breasts.
And I think we're just about at the end here in terms of cases, but this is something I really like to show because thermography is a new paradigm in terms of the conventional medical model. And this was a case going from left to right. There's inflammation in the knee there. And the second image, you can see kind of some small little straight dark lines. Those are actually acupuncture needles. And they're in every image going towards the right. So these were images taken every 5 minutes. Didn't include every image. I think they went half an hour. But you can watch in 5-minute increments the inflammation decrease. And I really love showing this slide to physicians because I remember the first time I saw it, it's obvious here that thermography is doing something different than what we were taught in medical school, because there's no vascular trunk here, there's no nerve trunk, there's no structural thing that is causing this inflammation to go away. There's no reason why, from a conventional medical structural point of view, you put needles in the knee and inflammation goes away. So one of the things I really love about thermography is I consider it a bridge between the alternative world and the conventional medical world. That if people if physicians particularly just stop long enough to really understand what it is and what it does, it really leads to a much better understanding of what alternative, quote unquote, medicine is really all about. In order to understand how these images are produced and what they can show, you have to develop a different understanding. So it really is a new paradigm in terms of the conventional medical point of view. So I think that's pretty much it for the slides. Did you have anything you wanted to add, John, before we go to questions?
Just one brief thing. When we were when you talked about your the carotids and that being one of your favorite slides, an area that I'm increasingly interested in and hope, because we live in a state where the weather is pretty nice most of the year, and therefore there's a lot of people who can engage in athletic activities throughout the year. Talking about precursors of disease, I've been reading about work that's being done primarily in Brazil, where they're pre-screening soccer clubs, football clubs, and just at the beginning of each season, just screening the knees of all their athletes. And if one knee is hotter than the other in an asymptomatic player, they're finding that it's extremely useful in helping to prevent injuries, because they can brace and tape the hot knee in a way that they might not if they hadn't done the thermogram. So I'm hoping that that's something that we'll actually be able to exploit here in Tampa at some point.
There's a lot of fascinating new areas. I'm very intrigued also by the allergy testing. That's relatively new. It's not being done in many places, but conventionally, to do allergy testing requires 20 different needles, under the skin to inject small little things. And with the thermogram, the substance doesn't even actually really have to touch the skin to give a thermal response. So it's pretty fascinating, and I see that as a interesting new area. So I guess whoever's there, we'd be happy to answer any questions anybody has.
Just turn on your audio, though.
So this is Nancy. Can you hear me?
Yes.
Okay. So I'm a general internist, and I see a lot of people with prediabetes or at risk or all those things that you're identifying, but it's still difficult to get people to make lifestyle changes, including me. I'm not above that either. I understand this can be motivating, because I think it's a visual representation for people. Sometimes they can't think about what diabetes is or see it or things like that. Are there any trials going on looking at this? Like, does it change people? Does it change their behavior, or current trials in that way? I think in some ways, maybe radiology is outpacing, and this happens a lot, the technology is outpacing what we're going to do with it at a practical level in the office setting.
I'm not aware of any studies. Are you, John?
Not that talk about it in, if I'm understanding the question correctly, in the terms that you like to use as it being a type of biofeedback, and does this actually impact, by getting this visual representation, does it actually change patients' behavior? No, I'm not aware of any studies. Although I would like to go back to, there are several studies with full text versions available on the internet search that have to do with screening feet in long-term diabetics. And there does seem to be some indication that thermographic findings can be predictive of who is going to develop a foot ulceration, which if you can intervene before the tissue actually breaks down, has some potential benefits.
That would be huge, yeah. What about people who have things like, for instance, women who've already had a breast biopsy and they have metal in there? Does that change the thermal print? Because you're looking at energy things, but now you have metal sitting there with it.
Doesn't seem to.
No, it doesn't seem to, although depending on the extent of the surgery, or usually with the clip, there's minimal tissue removed. But it is possible that if a woman's had extensive surgery, that we might have to reestablish a baseline. And you certainly don't want to do a thermogram within 3 to 6 months of a woman having any kind of surgical procedure or radiation to the breasts.
Mm-hmm.
Can you guys hear me?
Yes.
Yes.
Just had a client come in, 17 years old, who suffered from, I might not say this correctly, gigantomastia.
Gynecomastia.
Thank you. Thank you. She had 8 pounds of breast tissue removed from her breasts at the age of, I think it was 11, 12, something like that. And then in the following 3 years or so, she had additional, what her mother called lumpectomies. So we just did her initial breast scan, and I am very curious about how much that kind of surgery is affecting a young woman. I mean, obviously she's still growing, but isn't the myofascial, the lymphatic system, the vascular system going to be greatly affected by that amount of surgery?
Yeah.
And so are we still going to find a baseline in 3 months?
Well, I would say,
Tom?
yeah, I mean, my thoughts on that are that, yes, I mean, that kind of surgery is going to really change everything in terms of the lymphatics and the sympathetics and all of that. So I think that, but after that's done, you still can have a baseline. Now, if she's having surgery every couple of years, it's, an issue. But no matter what's really done to the breast, it may or may not change how it looks. I've seen lumpectomies where it doesn't seem to really change much. And then I've seen them where it changes a lot. But you have to then just reestablish, like John said, we kind of reestablish the baseline because we're starting after the surgical intervention. After that's done, and you have a 3 or 6 month, whatever it is, stable baseline, then it should be stable from then on.
Okay. I have another comment.
Sure.
Yes.
I've seen, just in this past month alone, and I've been scanning for over 9 years now, thyroids. There seems to be a real problem in this country with thyroid health. But a lot of folks that are having just full body scans for preventative purposes, thyroids are coming up, and sure enough, they go for, if they get a good thyroid panel performed, they are correlating very well with the thermograms.
Yeah, I see thyroid a lot, and I believe a lot of it's incidental based on the histories, that there's nothing, nothing mentioned in the history about it. I see it on a lot of breast scans. I see it a fair amount.
These patients are asymptomatic, and if they can get their practitioner to order a full thyroid panel, usually it's correlating real well with the thermogram.
See, and that's good to hear. And yes, I see a lot of thyroid activity over the thyroid, and I usually presume it's thyroid, and if I see it and there's nothing mentioned in the history, I will make that recommendation. We're at a disadvantage, especially not so much with Greenpoint, where we can obtain follow-up more easily, but when we're doing interpretations remotely for all of you, we don't always have in fact, almost never have the benefit of that follow-up. It would actually be useful to us, at least to me, I won't speak for anyone else, if, I did mention that in somebody who was asymptomatic who went on to have a thyroid dysfunction confirmed, to actually get some feedback by way of email or through Susan.
Well, I know I personally do give that kind of feedback. I would love a form. So Dr. Bartone, if you could produce some kind of this is me 20 years in the military talking, right? I want a form. So I would love to have something that, is standardized, and I'd be happy to fill it out and submit. And I think most of the thermographers would.
All right.
When you say there's thyroid dysfunction, is it overactive or underactive thyroid, or is it variable?
I would say that it's variable. I would say it's more often over function, and the pathology that I find most and it's purely anecdotal, but that I find correlates most consistently with an abnormal thermogram is a thyroid thermogram is something like Hashimoto's disease, where there's clearly inflammation as the underlying pathology.
Mm-hmm.
Yeah, it's not the same as like the hot nodule or cold nodule we talk about in medicine. That's based on a nuclear medicine scan.
Right.
That's what the definition of a hot nodule, cold nodule is. So I don't think that correlates exactly. In other words, if it's hot, quote unquote, if it's red on the thermogram, which was what I see most of the time. Sometimes we'll see it be hypothermic. But most of the time it's hyperthermic, but it doesn't necessarily mean, it doesn't fit that definition, that medical definition of a hot nodule. It just shows dysfunction, which could be a number of things.
No, and Hashimoto's, there's a hyperthyroid phase and a hypothyroid phase if it goes on too long, but it tends to be hot, that has to do with how the thyroid is functioning. But the thyroid, the bottom line is the thyroid is inflamed, and inflammation is going to show up as increased thermal activity.
Cardiac?
Cardiac.
Hello? Well, I had a patient once who had a very hypothermic pattern on her A2P scan, and on her left side, and it was just so clearly round and blue. And the patient, after I spoke with her, had admitted to a funny episode. She called it a funny episode one night, but other than that, could not, felt no problems. She was Mennonite. We have a lot of Mennonite and Amish people here in Iowa, and they don't go see physicians very often, apparently. So the report did come back suggesting that she maybe do some sort of cardiac stratification. But the interesting thing for this woman, and this speaks to what Dr. Hudson talked about when he was discussing the acupuncture screen, that this woman had heartbreak. It turns out she had a very sad story to tell, something very sad in her life at that time. And when I saw her 3 months later, that blue spot was almost gone. And she told me this wonderful story about how the problem had been solved, this sadness in her life. So I found it fascinating to see that energetic change in her scans.
Here's what I think. I really, truly believe that. I think that 10 years from now, we're going to be interpreting these a lot differently. And I think there is so much to do with the energy field and so many things that we don't yet understand. And one of the things, I'll give you an example, is we see that hypothermic area at T2 posteriorly.
Yes.
A lot. And it's associated with immune dysfunction, autoimmune dysfunction. It's associated with cancer at times. It's not specific, but it's associated with some immune issues in a lot of patients. And I believe, John, I was up in Tampa. We were at the acupuncturist office.
Oh, that's right. I forgot that you were there. I was
medically speaking,
about to relate that.
Yeah, there is no structure there. There is nothing there that's round that exists, right, from a medical anatomical point of view. And we were giving a presentation at an acupuncturist office in Tampa, John and I, and the acupuncturist said, "Oh yeah, that makes sense. That spot, it has to do with defense against the world. It was so it made perfect sense to him why this little T2 spot would be hypothermic." And what I really believe is that as this evolves and it becomes better understood, that there are going to be more energetic pieces. It's not going to be we're kind of interpreting this with sort of a conventional medical, right? We're looking for diseases. It's a conventional medical mindset, that general culture has. But I think more and more there's more energetic. You have to understand the energy fields and a lot of different things that I'm convinced with all the myofascial activity we see and that kind of stuff that we'll be able to tell a whole lot more things that we haven't even maybe imagined yet.
Can you hear me?
Yes.
This is Michelle. I'm not actually a thermography, but I've gotten it done. I'm actually a location for a lady here in Houston who does it out of my office. But when you said that about the energy, that was actually my experience. I had an iridologist tell me that she saw something in my eye for my breast. And I actually do reflexology. And she wasn't alarmed when she said it. She said, just get it checked out and try thermography. And about 6 months later, I was working on a client who had just had a baby and was having trouble breastfeeding. So I was working on her, and the baby started crying. So I asked her if she wanted to hold the baby while I worked on her, and she did. Well, the next morning, I had a pain in my breast that literally I couldn't even get out of the bed. And I went to see an acupuncturist, and it helped a little bit. But when I got the thermography done, it showed up, the heat showed up in the exact area of the pain. So I think I already had something going on, but I think it was the energy that I picked up from the mother that made it heighten. And so then it was necessary to address it. Then it became an issue. But I think it really is a factor.
This is Vivi. Can you hear me?
Yes.
I'm actually going on, something is going on with me right now. I'm treating a woman, and I'm a healer, with the severe issues with her right leg. And as better she became, and I'm seeing her like 8 months now, as worse my right leg is getting. So I start to think that I need to drop her. I mean, it really reached the point that I'm not walking as I used to walk, and I already forgot about my high heels. But she is a happy camper. So now when I'm entering to the thermography world, thanks to Pam, I'm wondering if I can see something.
I would say I don't know.
I would say there's only one way to find out.
That's right. Looking forward to.
And the beauty of thermography is there's really no downside to it. It's what I call a completely receptive modality. And by that, I mean we're not exposing you to anything. We're not injecting you with anything. We're not touching you in any way. So there's really no downside to taking a look.
Right. And I'm actually a mechanical engineer, have a master's degree in physics. So that is kind of like falls just right where I am. Prevention, wellness, and technology. I'm extremely excited from that opportunity. Thank you, Pam.
Oh.
All right.
Welcome aboard.
Thank you.
All right, everyone, it's about 8:30, so we've been on for about an hour. Any last questions for Dr. Tom or Dr. John before we wrap things up tonight?
Anyone?
All right, well, with that, I just want to say thank you, John and Tom. That was just a great overview. I appreciate your time and excellent information. So thank you very much for doing that for all of us.